Listen, thank you, all of the organizers of the summit for giving me this opportunity to speak. And just a few disclaimers at the beginning. My hope is to make this a sort of art of the possibility. So I want you to be thinking not about, oh, how doable is that today, but more thinking about what it's going to be, what the possibilities are for tomorrow and beyond. And the other thing is that I'm going to try to bring the perspective of the provider and the health system. I was a provider at one point, and I've worked with health systems for a long time. And so this might give like sort of the other side of the coin and what is necessary to get great acceptance and buy-in and really embracing AI and PI. Um, so let me get my technology working. Um, just by way of background, I have recently vacated my role at the Department of Health and Human Services. And it was an interesting but brief tenure there. But I've had these other experiences. I want to say again, I've been a provider, so I started my career as a clinician in general surgery. And I will say that's an interesting field because there's a lot of utilization and a lot of service provision with a very weak evidence base, and it is very, very high cost. So I am fully aware of that. Uh, I what got me moving from clinical care into sort of computational medicine and AI was as I was doing my general surgery training, two important things happened to me that shaped what I wanted to do with my career. The first was that I had the opportunity to work on the Human Genome Project, and I was doing the wet bench work, so doing the manual sequencing and something where you had to reassemble these little pieces of DNA and try to decipher longer and longer stretches of the human genome. And all that work was sort of useless. You generate all this data, but it was the computer scientists that sat next to me who were writing these programs to do probabilistic reassembly of this that I thought that's where the real insight gets generated. And then the second thing that really informed me about what my future would be was I realized as I was doing my training that clinicians do a lot of care and are not particularly good at recognizing patterns or making really sort of data-driven decisions on their own. And so that's when I realized that there was tremendous value in working in the area of clinical decision support. And that's sort of what led me into this kind of new area of computational medicine. All right, so I want to start again by starting with a paradox, which is um, we've made really substantial progress in applying AI to payment integrity. We're doing great automation of claims processing, good work detecting fraud, um, really good work streamlining prior authorizations and validating medical coding. But there is a little bit of a paradox because while they're working and driving real financial performance and fraud prevention, there is this uncomfortable truth where they're creating increasingly some fractures in the healthcare system, particularly with respect to the relationship to providers and health systems. Providers are telling us that these AI systems, despite their technical sophistication, are potentially compromising the relationship that the providers have with the payers, creating that strain that we've heard people talking about today. And there's also this perception that the whole PI system, and whether that's prior authorization all the way through to sort of claims denial, that's deprioritizing patient outcomes over sort of trying to make financial gains. Those are the perceptions that are out there with the providers. And then lastly, that there's a sense and tension increasing that the entire sort of controls that are put in place around reimbursement and claims are fundamentally creating barriers around innovation and more modern healthcare delivery processes. So today, I want to really explore and get you to think about what's possible in the future to attack this double-edged sword where we're gaining improvements in financial sort of integrity, um, but that it's not coming at the cost of compromising innovation in healthcare delivery. How do we actually create a bridge, in other words, that connects financial stewardship with clinical excellence and innovation in clinical care? So let me paint a little bit more of a picture of what's happening on the front lines where the physicians are trying to deliver care. And I'll really focus on what's this new area of precision medicine. First, very high cost, but holds tremendous opportunities. I say that more from a sort of clinical standpoint. So I think it's one of the most exciting frontiers in healthcare. We have providers who are beginning to deliver cutting edge personalized care. They're using genetic testing and biomarker driven therapies. And they're really defining treatment more at the molecular level. And in many areas, this is really not experimental anymore. It's truly evidence based interventions that can mean the difference between life or death, particularly in the area of oncology. But current AI-driven systems are often built on sort of historical utilization patterns. And they're also built on payment policies that have not yet been updated at the pace that this new innovative medicine is sort of taking off at. And so often these systems, this is the perception of the clinicians, is that it's this constant battle. These systems are flagging these as being experimental or anomalies when they're sort of interpreted by an overall historically trained AI system. And so it's that historical patterns and historical coverage policies that are not keeping up. They're lagging behind what are almost monthly releases of new diagnostic tests and flagging these as being highly expensive, highly specialized treatments, when in fact, the physicians are thinking that these should be the norm. Now, the tension gets even greater when we start to think about some new innovations in digital healthcare. We know healthcare is rapidly adopting remote monitoring, digital therapies, and these really innovative hybrid care models. And these are approaches that are often not just evidence-based, but they're more effective and patients really embrace them. And they're truly helping with overall better outcomes. Yet old payment integrity systems would interpret these innovative therapies and care delivery as being somewhat anomalous or suspicious, rather than being a component of a very progressive model of delivery. So when you think about it, a provider who might implement a remote monitoring program trying to avoid a hospital readmission, and it theoretically improves patient outcomes, that could get flagged by a conventional billing or payment integrity system because it really just doesn't fit with legacy patterns on which the systems have been trained. And then last sort of area of kind of tension that's been developed is we're seeing this disconnect with these new value-based models. So many providers are increasingly working with these contracts that incentivize long-term outcomes and population health over episodic care delivery. And while the providers in the health systems might be enrolled in a specific value-based contract, they try to really roll that out across their entire panel. So if they have a mixed panel, some of whom are in a traditional fee-for-service with a much more conventional claims system, they're going to run into these conflicts where they're delivering a new model, which is optimizing for long-term outcomes, but claims or services are being flagged as being overutilization when they're looked at from a kind of a traditional episodic care delivery lens. And so that's sort of a third area where there's some tension that's developing. And so this brings us to this fundamental question, which is AI destined to be an unbridgeable chasm between financial oversight and clinical innovation? Or can it become this bridging function that connects the two? So I'm going to have you start thinking. I'm going to take you through some really sort of forward thinking. I'm not saying that we're ready now, but if we don't start thinking about what's possible, we won't be taking the steps to get there and build this bridge. So let's talk about the vision. First, I want to talk about what really is required to get providers to accept advanced AI and payment integrity. So I'll start with the basics. And the basics are that we need in some way to prove that our technology is actually addressing the pressure points that providers are facing every day. And that's everything from just the traditional care delivery challenges that they face to clinical operations bottlenecks, obviously the revenue optimization needs that they have, and regulatory compliance demands that they're constantly facing. But probably more fundamentally, I think we need to address or resolve what's I think of or I call the rigidity problem. And this is where traditional payment integrity still mostly relies on rule-based systems that really are essentially codifying yesterday's medical knowledge into today's coverage decisions. And we're now entering an era where there's such rapid evolution of the evidence base and the way in which we're actually figuring out how to treat patients. And there's increasingly sophisticated precision medicine models that this approach is not just inadequate, it's actually often very counterproductive. So that's just the basics that we have to try to achieve. The next level is that we have to really work on what I call sort of seamless integration. And that means that our AI and PI can't be something that disrupts existing workflow. It really needs to enhance the workflows that the clinicians have in their offices. It should be working behind the scenes and in some way continuously amplifying the provider's expertise by surfacing insights that support smarter decisions and continuously improve provider revenue cycle at the point of care, not after the fact. So it's not introducing a whole new interruptive and disruptive workflow to respond to sort of denials. It's really at the time, at the point of care, helping these clinicians think about smarter decisions before they actually even do the ordering or do the delivery of the care. Now, here's where the real vision is. The dream is what I call the validation paradigm. And this would be that instead of blocking innovation, that revolutionary AI-enabled payment integrity should dynamically be assessing treatment options against real-time clinical evidence, patient biology, emerging guidelines, and sort of instantly validating innovation rather than reflexively denying it. So this is sort of imagining transforming payment integrity from a backwards-looking auditing function, which is largely what it has been, into something that's very much a forward-looking clinical intelligence partner to the clinician and to the medical group and to the health system. And that intelligence partner is rapidly evolving just as the evidence base itself is. And so the goal isn't just accurate coding or accurate claims. It's really to dramatically reduce this lag time between emerging evidence and coverage decisions. And that could potentially disrupt that inevitable cycle of submit, deny, and be sort of proactively helping at the point of care. So I've sort of laid out what's necessary for provider acceptance and what the vision is. But how do we get there? How do we get beyond the conventional status quo around payment integrity? Well, let's start with what is the technical foundation that's necessary. Now, I'm a data scientist and really heavily a data person, so I always begin with the foundation being data. And what we really need is a better sort of unified data architecture. Most of PI right now is based on claims history, training on claims history, training on medical policies. We've already talked about the lag, but that's not the only source of information on which you could build these really sophisticated, intelligence-enabling PI systems. If we want to achieve broader goals, we want these AI PI systems to be simultaneously processing data that comes from the EHR, from specialty guidelines, maybe FDA updates, payer policies, and also real-world evidence. Now, these each update on different schedules, so it's not a simple solution. And it's not just bigger databases, it's really more of a data orchestration engine that can harmonize multiple sources coming in real time and creating almost a single source of truth that would tell you exactly what's a qualified utilization, a qualified treatment pattern at that time for that type of patient. but aligning with the financial realities of the health insurance system. Now, the data integration is just the first part of the puzzle. We also need to have the ability to do much more continuous model evolution. We move away from these static payment integrity models that are rules-based or trained on sort of a static snapshot of intelligence at that time, moving it to much more of a dynamic training system. These traditional models that are trained on historical data really can be absolutely obsolete within months when you're in an area where there's such rapid evolution of care and evidence. So we need AI architectures that can incorporate, again, information, knowledge, intelligence from new guidelines and regulations in real time, maintain the learn patterns, so certainly that's around sort of patterns that look suspicious or are truly fraudulent, but adapting to new information as it's coming in. This is having AI and PI evolving as fast as medicine and evidence is itself. And then critically, we also need what I call sort of an adaptive ground truth. So this is the ability to better define what's appropriate care or cost-effective care. And that can change, again, as evidence is evolving. And if you're over-relying on a historical pattern of claims and historical medical payment policies, that's giving you a misleading benchmark or standard around what's cost-effective or appropriate. So we want systems that are going to be able to revalidate decisions against current standards. And they need to be able to self-correct in several different ways. First, self-correct or learn not just based on the new evidence coming in, but also be able to integrate these other controls. And this is around using AI in a dual way. So taking a look at tracking patient outcomes against AI approved and AI denied, making sure that it's continually tuning itself and validating the way in which it's been actually executing decisions or recommending decisions. And really constantly validating again around things like shifts in consensus. So we do know that there's a shift, there's a constant flux of consensus by experts in the field, by guidelines, and by professional organizations. And so using AI to also be sort of constantly tuning and assessing the decisions that it's recommending or making against what it's seeing as trends amongst the experts in the field. And so this feedback loop that you could build into these AI systems would allow you also to incorporate appeals data and physician override to really be constantly evaluating just how effectively this AI model is learning. And then also be continuously looking at peer review decisions and clinical audit findings, again, to validate, measure its effectiveness, do some reinforcement learning. So here's how it would sort of look. Let's say we have an AI system that initially denies coverage for treatment A, but of course, based on a 2022 guideline, that may be the most recent. But the system begins to detect increasing physician appeals for that denial of the treatment A. And while the literature monitoring begins to see new studies coming out that maybe are supporting treatment A, the model begins to recognize there's been a consensus shift, even before it waits for that official republication of a guideline. So it may automatically adjust criteria for treatment A, and future decisions might now be reflecting this shift in the clinical opinion and clinical understanding and the consensus opinion by the experts in the field. Now, there's also a need to improve the predictive rather than reactive characteristics of these PI systems. So instead of always being behind the curve, and I use this image here, I'm from Boston. Anyone in the audience who lived in Boston 10 years ago and rode the red line, there was constantly delays being flashed up. And so instead of being behind the curve where a PI system is contributing to the delays in reimbursement or approval of treatment if it's prior authorization, it should be really able to anticipate or predict future coverage needs from clinical outcomes and new patterns that are coming out of the consensus guidelines. So imagine this, that it looks at the evidence, and even before it's faced with this task of doing a coverage determination, it can anticipate budget implications of emerging treatments and begin to think about framing proactive coverage decisions rather than waiting for sort of a reactive scramble for policy change. That's a real blue sky opportunity, but I think it's there. Here you're using AI to be literally helping you think about what is coming before the utilization requests come in, auto-correcting, evaluating what the financial implications are, and sort of anticipating how you're going to have to reshape communications and get ready for this. Now, context is everything. And again, another change, another blue sky hope is that moving away from these traditional approaches where we're looking at an episodic claim or trying to make a decision about a claim status, we know it often is missing the clinical context. So think about an AI enhancement with a richer data foundation where it is able to look at much more of the longitudinal history and look at the trajectory and make decisions around legitimate treatment and progression and be able to differentiate that from inappropriate versus appropriate patterns of care. And this is a level of intelligence where it's really understanding a lot more on its own around these concepts of step therapy, tolerance, chronic disease management, and care pathway compliance. And so is able to make a much more sophisticated recommendation around approval rather than just simply rejecting. Of course, this is dependent on that foundation that I talked about earlier, where there is this ability to have access to EHR data, to supplement claims data, or at least some real evolution or dramatic change in the way we codify claims. Right now, very restricted, very sort of atomic, and strips out a lot of the context that would actually help you differentiate between an appropriate utilization event versus an inappropriate one. Now, I had already talked about the necessity for seamlessness, so integration and timing are really critical. We need these systems to be better embedded into what is truly an EHR-centric workflow. So this is the ability to actually have these systems at the point of care and really providing true decision support with instant sort of accuracy in the way you're codifying, and instantly presenting the clinician with prior authorization requirements and reimbursement optimization techniques. And so again, it's from a timing standpoint, it's really giving those insights when the provider is still with the patient. Before the event has occurred, you're not having to deal with it after the claim submission, you're really there and helping out with the decision-making right as the clinician is sort of choosing treatments, choosing ordering, et cetera. And so I think of this as not unlike the difference between trying to predict the weather based on some historical review from, decades or years gone by versus current technology where you're looking at real-time Doppler and it's conferring immediate awareness based on current conditions. So that's the metaphor that I like to think about. So in some ways, what I'm actually talking about is a convergence opportunity. And here is something that I think is really fascinating, which is the boundary between what I sort of built my career on, which was traditional clinical decision support, versus payment integrity. And I think that is increasingly blurring. And I think that is where we need to be in the future, where these two systems that historically operated in separate domains with separate stakeholders and timeframes and success metrics come together. And so now what we have is an advanced AI system that is simultaneously recommending the most clinically appropriate treatment. Of course, that was historically a clinical decision support system. It's identifying the most cost-effective equivalent option, which of course was historically a PI function. It's flagging in real time potential coding optimization opportunities. Again, a historic PI function. and then suggesting care pathways and modifications for better outcomes, and that would be historically a clinical decision support function. And so imagine a world where these are actually indistinguishable. Of course, they both require a deep understanding of the clinical evidence base and real-time point of care capabilities. But I think that this convergence is really the unprecedented opportunity that we have. And that is what's going to create alignment versus conflict between the health insurance sector and the providers. Now, the last thing that's really critical, and then I'm going to take you through an example if I have enough time, sort of doing a time check here, is that none of this would ever work, though, unless we have better transparency around automated decisions. And what this requires is fundamentally a whole new component to AI and PI, which is some explainability component. The market is increasingly demanding that there's transparency in automated decisions, and that's true in healthcare, it's true in finance, it's true in many other sectors. Provider confidence in the appropriateness and the fairness of an AI-facilitated decision is going to require some level of understanding of what led to that response. What was the reasoning behind this? And the regulatory reality is increasingly asking us if there's something around approval or denial, you need to have some ability to trace how you got to that denial answer. And so I like to talk, when I talk with folks, I like to frame this as being transforming from computer says no to here is why and how to change the outcome of that decision. So again, going back to something that is really, I think, an area of intense focus now, which is precision medicine, very high cost, very, very complex, prone to denials with tremendous effort put into appeals. And it's an area where there's particular tension because we're seeing monthly new diagnostic testing that's coming out. And yet policies at best are like annually updated, if even then. So there's tremendous tension there. And it does not work with hard-coded legacy systems that really can't adapt to this rapidly evolving molecular targets and testing methodologies. So the reason why a black box AI model is not going to work is then, again, this policy technology time gap. And there's often a clinical utility disconnect with conventional AI models that don't sort of take you through the rationale. And that's where it's looking mostly at diagnostic accuracy and making a determination about whether it's hitting a threshold versus whether or not that test is actually going to change decision-making clinically. And lastly, the sheer complexity. I don't know when the last time you've looked at one of these really advanced sort of second, third line therapies based on molecular profiles. As you read through those medical policies, you can take 2 or 3 commercial payers, and they are, in essence, codifying the same treatment pathways, but they're so difficult to interpret. And I say that just from my own personal experience, I found it incredibly challenging. And then when that gets codified and these AI systems are generating a denial versus approval with no ability to trace how that decision was made. So how do we go from that black box to a transparent answer? And this is around, again, dynamic knowledge integration. And this is sort of how it would look. I like to talk about something, it's conceptually similar to what I call simulation-based scenario exploration. So let me go back. There we go. So explainable AI, particularly with this specific technique called counterfactual reasoning, would do this. It would not just output a response or a decision. It would instead provide for the end user what would have to change for this decision to be different. Why was this case significantly different from other ones? What's the smallest change that might need to be made in terms of either the sequence of care or what particular test is done to make the difference between denial versus approval? And how sensitive is this decision to other factors? That's the really advanced counterfactual reasoning that you could embed in your AI that would make a tremendous difference and make these decisions very transparent. Now, it can actually potentially affect two different workflows. On the payer side, it can affect the reviewers, the claim reviewer or utilization management reviewers workflow, and it can also radically change the provider workflow. So I'll walk you through the reviewer workflow. So if you embedded this more advanced explainable AI component, this is what the reviewer would see in a particularly complex decision process. They would get a question scenario. What if the patient had a strong family history? And then they review the record and it enables them to go through, get an explanation and an approval. Scenario 2, what if the patient had failed their first-line therapy? Much easier for them to look through the medical record, quickly go through this. It presents them with the clinical utility score and an explanation of approval, and there's much more rapid sort of ability to validate and finalize this decision. Scenario 3, what if the target testing was already performed? Oh, goes through, explains that the key tests that were components of this already were helpful, that there's very little clinical utility for this additional testing, and deny. So it gives the reviewer, the human reviewer, the ability to finalize that decision that was enabled by AI analysis. So that's the reviewer workflow. Now, what would the provider workflow? Again, same underlying technology with this explainable AI component added in. And imagine, again, at the point of care where the request is being made for authorization, that the provider gets this back. Alternative approval pathways. So you're telling them, you're guiding them through what needs to be true for this to get approved rather than just simply approval versus denial. So first, give us more enhanced clinical documentation and it outputs the next steps. Pathway 2, treatment failure documentation. Tell us why or where the evidence is for a treatment to have failed already, and then what the next steps would be. Pathway 3, pathway to get immediate approval. Just do the targeted 4 gene testing and we'll approve it immediately. And that is giving them, again, at the point of ordering, the pathway through to how they're going to get this care approved without this long lag and delay and a sort of a black box decision, which gives them no insight. And this is where you begin to get this virtuous cycle of education, which is just not at that transaction, but the clinician begins to see what exactly are the paths, what is the basis for this decision, and again, with the intent of reducing that friction that's existing between the clinicians. Now, what would be the implementation strategy around this? I'm a fan of incrementalism versus big bang. Again, trying to do little things and figure out where you're going to get tremendous gains and begin to improve that relationship between the providers and the health plans. So the question isn't whether to implement, but it's just how to go about it. You want to think about areas, again, where there's particular complexity, particularly rapid evolution of the treatment pathways, and where there is increased anxiety by providers who are trying to develop new innovations in care, but are really feeling as though there's barriers being placed or resistance being presented to them by the payers. And so this is things like high complexity, high stakes scenarios, very high costs. Those would be also areas where there's already significant financial materiality or fraud risk, maybe higher regulatory exposure or stakeholder sensitivity. So precision oncology, high-cost pharmaceuticals, and this definitely appeals to me, which is complex surgical interventions, which often are based on relatively weak evidence, and there may be much more simplified approaches. The idea here is we begin to get this flywheel effect, right? Where first you begin with the system where when implemented right, the AI systems are built on much more real-world evidence. They're continuously learning from treatment effectiveness. They're looking at the patterns of overrides between the clinicians and evolving standards. And so that's actually making these AI systems work much better. But then that flywheel effect means that the organization is actually improving. So these algorithms, which are augmented particularly with explanations, help providers improve their expertise. And it really streamlines payer reviews on the payer side. So the individuals or those reviewing are often able to see the very clear logic, the flow of logic. Of course, you also want to be thinking about the potential for regulatory scrutiny. And so these explainable AI systems give you this built-in transparency where if audited, you could actually walk the regulators through what was the sequence and the logic and the foundation, the evidence base for those decisions. And this is really giving you then, moving on, this ability to move cost avoidance way upstream, or I think the metaphor we've been using today is to the left versus the right, where you're preventing low-value utilization even before the claim gets submitted. Overall, all of these things together are really aimed at reducing what are these adversarial dynamics that have been building up and creating a true sense of a shared understanding between the payers and the payment integrity specialists, as well as the providers and the health systems. So I truly believe that we can use AI in a more sophisticated version of yesterday's rules. And so we're avoiding creating this ever-increasing chasm between financial oversight and clinical innovation. And we're reimagining AI as a bridging function. And so this is one that connects rigorous financial stewardship with support for medical progress. I'm sure that the technology exists today. I know that the opportunity is clear. And the question is, do we have the vision and the stamina to build bridges instead of walls between the payment system and the providers? I have tremendous hope, especially after meeting many of you today. I think you're all very passionate about this and very capable. And we just have to be thinking very, very much towards the future and what's possible. I love ending with this final thought, and this is Dame Janet Thornton, who played a tremendous role in the use of AI around the predicting protein, tertiary protein structure, which is becoming revolutionary in developing new medications. And she says that this isn't the end of something, it's really the beginning of many new things. So I'm going to stop. Hopefully there'll be one or two questions from the audience. It'll make me feel as though you reacted to one or two messages. Questions?
Thank you for that presentation. I had a quick question just about how your thoughts on how this could happen, because it seems like that AI vendor might almost be like a natural monopoly. So would you see a lot of consolidation within, payers and as a natural result or byproduct of what's
So,
land?
yeah, in trying to answer that question, I would say there needs to be almost a different model of how things are, how we're approaching this problem. I think there needs to be a sense of a holistic view of things where you're eliminating some of that middleman and you're bringing the providers and whether it's independent vendors who are doing this or payers, you're bringing them together and approaching this more as a overall clinical decision support. You're saying, we're working with you to help you make better decisions. And it requires, again, sort of thinking about not just optimizing around financial stewardship or financial performance, but really optimizing around the best and most appropriate and cost-effective care. So it almost is redefining what the roles are, but creating this true collaboration. And what it may require is the removal of some some parties that are involved. I personally believe that EHR vendors, I hope we don't have any in the audience, I have a very negative view of them. And this is coming from early in my career. We built our own EHR system before Epic even existed. And we built it based on how to actually enable clinicians to work more effectively and to document the correct parts of the clinical episodes of care that help them then pick it up with the next encounter. And it's totally changed now. They've become overly complex and they're really just optimizing for revenue cycle management. So they're not even capturing the information that's necessary for longitudinal patient care. So I actually think in some way removing them and bringing together instead sort of the financing of health of medical care delivery and the delivery arm itself together is actually potentially going to be better.
State. Uh, so that's kind of a two-part question about behavior. Sorry, about human behavior and organizational behavior, right? So clinical decision support. Physicians are perhaps the most difficult customers when it comes to technology, and so they're very hard to get them to use it, especially if it's used as a process control on their ability to deliver it, right? Because they don't like to change their ways. I've been doing this for 30 years. Why would I change now? So I was kind of wanted your thoughts there. And then on the organizational behavior, right? The incremental approach, I agree with it. But then you have things like the stress on the healthcare system that needs change, or the stress on for profit organizations where you have to implement it in order to drive additional revenues within a quarter. So, what are your thoughts on balancing both the human behavior as well as the
Okay.
organizational behavior?
Hard to answer that in a minute or two, but here's my take on it. So first, I think um, clinicians' reluctance to embrace technology is partly because I think there's been a long history of technology being foisted upon them. And I'll even say that, which the HITECH Act, while it was intended to be helpful, it actually was premature, which is that it mandated, wholesale EHR implementation before the technology was really ready to do it. And it was awful and it was incredibly disruptive and extraordinarily expensive. And I'm just going to give you a sense of a price tag. So we're implementing Epic finally in the old health system where we had built our own. It wasn't great, but it certainly was very cost effective. This Epic implementation is going to be way north of $1 billion. I'm not joking. And the margins right now in healthcare systems are very, very thin. So first is this legacy of technology being foisted upon them, not particularly thought out. It is not like consumer electronics where they think about sort of the human-centered use first and then build around that. This is almost like after the fact, right? Which is they think about what they're trying to optimize. And really what EHR systems have been trying to optimize is mostly around revenue cycle, compliance with multiplicity of payer policies, and then compliance with regulatory, right? You have to get this meaningful use component in to make sure you're getting the maximum reimbursement by CMS. So just the absolute opposite. So that sort of sets the tone for why there's been reluctance. I think that's going to change. I totally, I'm going to make my prediction, which is that right now the world is dominated mostly by Epic, a little bit still with Cerner, very, very bad experience. I'm predicting in the next couple of years, potentially with AI enablement, that there's going to be a radical change to the way like what we think of as EHRs. And that's going to break open all sorts of possibilities. First, it's also going to increase provider sort of satisfaction because I think these are going to be developed in a way that is very much centered on the interaction between the patient and the provider, both in a specific episode as well as long term. So that's that. Now, related to that is this idea of organizational behavior, which is that I've learned the hard way. Um, the first thing that you need to do is assess the organizational capacity and readiness to take new technology in. And it may be that there's something else going on and that they otherwise would be ready for innovation, but there's some other thing going on. There's been a particularly problematic series of contract negotiations. There's been some change in the payer mix. There's been some consolidation by a competitor, all sorts of things. And it's just not the right time to innovate or bring in some new technology. So a lot of this is around accurately assessing the capacity. And maybe it's at an individual health system, maybe it's in a multidisciplinary provider group, or maybe it's in a region, or maybe it's with an entire sort of payer block. So it's, managed Medicaid or managed Medicare. So you need to be very careful about that. And that's around selecting, when you're trying to do something truly innovative around payment integrity, picking an organization, however small or large, that it's just the right timing. They have the capacity to change, the willingness to be a true partner. And then that's going to increase the probability of success. I don't know if that answered your question, but that's around this idea of organizational behavior and readiness and capacity to absorb innovation.
Well, I'd like to first say, like, you just took what I said and took it to a whole nother level. So thank you.
Well, thank you for setting me up for success.
Because if you are able to do what you just talked about with new technologies and being able to make those decisions on evidence-based medicine at the point of care and affect that clinical decision making, then surely you can take all of these hundreds of Boolean logic statements and those millions of code pairs I talked about and make it so the providers can send in claims the right way the first time and make that differentiated by payers. And so what I am envisioning is that all should be brought up into the practice management system and not wait for even the gateway to happen. So yay, you just validated my hypothesis. My question to you though is, are we conflating, well, let me just make a statement first that we were having last night, that many times we all agree, I think we all agree that things that are technical denials in PI can be avoided, right? Like you put this in the wrong slot, these two modifiers don't go together. But things that are like bundling, like this is subsumed into this code, that is something that they're reluctant to tell the provider, well, just don't send in that code that's not going to get paid, right? Or that ENM that came after a surgery that, you're not going to get paid for it, but send it in because I want to see the utilization. So are we conflating the payment mechanism with care management?
So that's a great question. And I would say maybe I'll either be deflecting a response or answering in a slightly different way, which is that these two things have been sort of parallel things, and they go together. So they go together in a specific way, which is that the reality is it costs a lot to deliver health care, and it's not sustainable on its current trajectory. So you can't just ignore inefficiencies, inappropriate use, whatever. That's an important component. I don't know that providers are totally getting that. I think they're instead just living kind of encounter to encounter saying, am I going to get reimbursed for this? At the same time, the clinicians need a much more, there needs to be a way in which they're sort of co-informing, right? Which is the ability to sort of say, give me some evidence that helps me know this was the right sort of decision or the right order or the right sort of level of care, and then I'll give you a fair reimbursement. But the clinician also needs to be informed of, hey, that's not necessarily the most cost-effective way. And how those two things can come together in real time, that's the challenge we're going to face, right? But it's a totally different way of thinking about this. Now, I am ignoring some other realities, which is I do know there's fraud, that needs to go on the way it's always gone on. I'm really more talking about sort of cost effectiveness and having this true partnership. And the two have been sort of separate, sort of asynchronous. And that's where the tension is. And how do you bring the two things together? Well, one way is you have one unified payer, right? That's not going to happen anytime soon. And nor does it solve all the problems, but instead that there's this collaboration, which enables everyone to move toward a more financially sustainable, more evidence-based way of delivering care. I hope most of you aren't thinking I'm just pie in the sky. I do believe we can get there. I just feel as though the way we originated and the way these systems have operated sort of separately has just not created the right conditions. But AI and access to data and the ability to access much more diverse sets of data really give us that potential to change.
The payment integrity, if you go back to that, how does innovation actually make its way into the payment integrity side? It's not just because a doctor says it, that's probably not the only thing that we need.
Well, so the interesting thing is the payment integrity system. So if you have the full view of all of the utilization and sort of an indirect view of outcomes of populations, right? You really are reasonably, and I'm glossing over a lot of things, which is like each payer is only looking at that, the experience of that population in their covered universe. But imagine if you had the ability to actually be looking across a very diverse population, that you have access to the ability to sort of begin to see which innovations, not just in a controlled setting and the evidence base sort of generated some indirect evidence of its effectiveness, but now you're looking not only at clinical effectiveness, but long-term cost effectiveness. You do have access to that ability to look at long-term cost effectiveness. And I think that we're not really doing a sort of continuous evaluation and feedback that enables us to begin to make, not wait for a policy to go into effect, but just say, hey, there's growing evidence in the data itself that's indicating that this is appropriate.
I mean, basically, this is a dispute kind of thing, right, between payers versus providers. So, would there be like something like a neutral, maybe a government managed agency or something, which would proactively deals with this and sets out the rules? Would something like that work?
I would say my immediate reaction is that's not a good path. You really don't like it. I've been really advocating for bringing closer and closer together the financial realities, right? What are the financial realities of paying for healthcare coverage with the clinical realities of just trying to take care of patients. And I would say probably of everything I said today, the greatest yield or lift would be from just being able to move explainability of decisions upstream, because then there's more of a sense of and I'm a clinician, so I can always say, I fall back on that. I'm a clinician, I can say, we make dumb decisions or we make decisions that are time pressure decisions. We don't intentionally make bad overutilization decisions, but we make decisions that aren't the best informed, and we also don't integrate learning like we should. And I think that's really where probably of everything I've said today, that's where I hope to get the most yield, which is you're bringing the logic and the flow and the explanation upstream, and there's that opportunity to learn, so the next time around there isn't a submission, there's actually learning and integration of that and a much more informed decision first about whether or not to do that utilization or that treatment, and then if the choice is there, to understand what needs to be submitted with documentation to increase the probability of it getting approved on or paid on the first cycle through. So, well, thank you all for your attention. I really appreciate it.